Everybody, welcome to Provincial Stroke Rounds. My name is Heather Jenkins and I'm the Regional Education Coordinator with the Stroke Network of Southeastern Ontario in Kingston, Ontario. So I should let everybody know that we've had some major internet difficulties this morning, and I was going to be playing this song for you on the request of Dr. Finestone due to its significance and relevance to the topic, but alas, without internet, I'm unable to do so. So my apologies for that. Feel free to look it up on Spotify or Google. Today's presentation is titled Driving After Stroke, the Art, Science, Legal Implications, and Headaches of Reporting Our Patients. We have, let me just take a really quick peek in the group. We have 100 people joining the call today already. We had many more than that signed up, so hopefully we'll have some stragglers joining as the presentation goes along. I have sent out your handouts yesterday in a packet, so you do have these slides already. And as this session is being recorded, it will be posted to our network's YouTube channel and a link posted on our website so that you can access it after the fact should you wish to view it again. Please check that all of your microphones are muted, and they should remain on mute for the duration of the presentation. We will have time for questions and discussions at the very end, last 10 minutes or so, and what we will do to hope to hear from as many folks as possible, please ask your questions by typing them into the chat box, and they'll be answered in turn. Those, if anybody is calling in, I'll offer an opportunity to those on the phone to ask a question as well. There's your evaluation survey link. It'll appear at the end as well, and it is in the handouts. Please do take the time to follow either the link or use the QR code to access and complete the survey. We value your feedback, and certainly we do everything we can to follow your feedback and improve these rounds. You've also been sent an attendance form, so if anybody is gathering in a room, 2, 3, 4 in a room, please fill out the attendance sheet and send it to me at the email address at the bottom. Certificates of attendance were also circulated, and you may fill out those by putting your name on them and saving them for your own records for future. The Provincial Stroke Rounds Committee has mitigated bias by ensuring there is no industry involvement in either in planning or the content of this presentation. And now it gives me great pleasure to introduce this morning's speaker. Dr. Finestone is a specialist in physical medicine and rehabilitation, or physiatrist. He graduated from McGill Medical School, received phys med and rehab specialty training at universities of Ottawa and Michigan. He is a professor in the Department of Medicine, Division of Physical Medicine and Rehabilitation at the University of Ottawa, Director of Stroke Rehabilitation Research at the Elizabeth Brayer Hospital, Brayer Continuing Care, and electromyographer at the Ottawa Hospital Rehabilitation Centre. Dr. Finestone is a contributing author to the CMA Driver's Guide, Determining Medical Fitness to Operate Motor Vehicles, 9th edition, Section 15, Cerebrovascular Disease, and is co-author of a number of other driving-related peer-reviewed publications. Dr. Finestone, the floor is yours.
Thank you so much, Heather, for this warm welcome, and it's been a wonderful opportunity to share some information with Southeastern Ontario and all of the province. So our topic today is driving after stroke, and we sort of put a long title: the art, the science, the legal, and the headache.
I don't know. No, it's not there. Because I just found the link.
Could I remind everybody to please mute your microphones? Thank you. Not you, Dr. Finestone. Could you unmute your microphone, please?
Yes, sorry.
Thank you.
I unmuted before. Okay, so we're talking about science. Still there? Here. How's it going? So the headaches, and so we're going to talk today, myself, and I'd like to acknowledge basically co-authored Lynn Hunt. We've always wanted to give a talk together. Lynn is an OT through the Ottawa Hospital Rehabilitation Center, and unfortunately, Lynn had a car accident in August that it affected a bit of our planning. But she's in the audience today, and she's contributed greatly to the slides, and I'm so happy that that was able to happen. And I'm advancing my slides, and we have no actual conflict. I'd like to acknowledge Dr. Catherine Ballack, physiatrist, and Elke Hildengard, occupational therapist.
We've lost your sound again, Dr. Finestone.
Yep, I've got my slide back again, and so Dr. Ballack, physiatrist, Elke Hildengard, and my shared some slides, and I thank them for that. And Dr. Marshall, my mentor, my chief, my friend, and who's world famous, really, driving researcher out of the Ottawa Hospital Rehabilitation Center, University of Ottawa. Some slides are wandered in here too. And we got the 2018 MTO legislation from online and other sources. Next. So this is me. You've already introduced me. Thank you very much. And Lynn is an occupational therapist. She actually, she's retired from the rehabilitation center, but still actually not retired, so still doing assessments and specialist for the Association for Driver Rehabilitation Specialists, ADID. So what are our objectives? To understand how stroke survivors can affect driving, appreciate how some of the screening measures we do, like really probably should say not only medical, but and other functional assessments by multiple other healthcare providers, and wisely exercise our evaluation and judgment according to these new 2018 guidelines, which we will go in quite detail because I think it's important to really know what's out there. And so really this talk has about a bunch of components. It's a kind of distillation of just years of discussion with Lynn, with myself, with all our healthcare providers, with the headaches, with Jane Sommer, outpatient RN nurse. So to get more clarity. And so some of these things are written, some of these things are just figured we've got to get out there, and we'll have some time to discuss later. And so we'll have some cases, we'll look at the guidelines, we'll evaluate really what we do, and sort of end up with some real commentary. Gruyere is in Ottawa, and this is what it looks like. Little snow on the ground lately. So why is driving important? It's because it's such an important part in today's society, the lifestyle, freedom, and particularly in rural areas. Giving up driving is correlated with mood disorders like depression. And we know that driving promotes life satisfaction and quality of life, probably for everyone, but it says on the slide, older people. What are some stats? 50,000 people suffer a stroke each year. About probably less than half will resume driving. Less than 35% of stroke survivors discuss driving because it's such a hot, inflammatory sometimes topic. 87% of stroke survivors will start driving again without having a formal driving assessment. So what do we know? We know it's a complex skill. It's not just physical, it's not just mental, it's not just visual, it's a combination. Driving, and we have to say this to our clients and our patients frequently, driving is a privilege. When our patient says, Dr. Finestone, driving is my right. Well, we know it isn't a right, it's a privilege. Is mobility a right? People have said mobility is a right in society. I wrote, is it, just being a little controversial? I guess it is, but sometimes I suppose, like, you know, with the scraped down sidewalks, but sometimes people still have trouble with mobility. And drivers, this was I got from some other slide, that drivers are required to take responsibility for their change in medical status. And that was an interesting question. So are they really? So in Ontario, if we go online and say, what are the driver's responsibilities? Well, there's a lot of things that they say that the patient can do. Report to your doctor if you're having changes, avoid driving, if you have pain, and you should maybe get into an exercise program, maybe take a course if you don't think your driving is so good. But the reality is there's no mandatory reporting on behalf of the patient to report their condition. Just when their license is being renewed, then they have to report that. So that's an interesting fact. So what are our roles? You know, these are things we're always thinking about. So we tried to distill out some information. We're screening our patients. We're looking at that aspect of driving. We're looking for clues that may have an impact on our patient's ability to drive safely. And we're looking at so many different factors: historical, physical, visual, cognitive, visuospatial, communicative, or even psychological, which could affect their ability to drive a vehicle safely. So I said, we're like driving detectives. And I write, we're nice because we have to say we are trying to do our best, and we are usually nice, but it's not such a nice environment that we have to be working in, and we have to recognize that. We have to share that with each other, that it's very difficult sometimes to discuss this topic, and it's been shown, for instance, that maybe people don't show up to their family doctor as much after the driving issue has been discussed. So I know I got this from Sean Marshall. So what are the top medical conditions that are risk factors for stroke, relative risks? As you can see in the top 5, actually stroke's not in there. Sleep apnea is huge, and other things like alcohol dependency are, in this case, runner-up and second with mental health disease of schizophrenia. If we have a bigger chart of relative risk, we see there's a lot of other diseases. Stroke is kind of right in the middle there. Traumatic brain injury alongside, and these are kind of there's a few studies that you see have been listed that are purportedly providing a relative risk that there's a greater chance of having a stroke. So I've been told I'm muted again, so I'm back unmuted. That as Dr. Marshall said, like still people are driving under the influence, for instance, of alcohol and drugs, and most people are still not having accidents, but there's a relative risk to it. Okay, next. And so let's look at some particular cases, so to give us some framework that we could use these cases also later on in the talk. So our first case is, I sort of think that there's some things we know, and there's some things that are less clear, and there's some things that are very clear. So I call this the driving outcome. Person's had a stroke. It's quite a big to a large size right temporal parietal infarct. Patient was on acute care for about 3 weeks. Patient has left upper and lower extremity weakness, walking with a walker, still needs an assist with a therapist, bumping into objects on the left. The MOCA is 23 out of 30. The clock is 2 out of 5. And the driving history, when we ask the family, because we usually don't get this information from our patients, is that the family says, yeah, they've had 2 accidents. And this was a line that I just threw in very recently, in that when a wife said about her husband, she said, Dr. Finestone, only after asking, I really didn't want to drive with him over the last 6 months. And so these are some of the findings, and just crossed the lines, and you see the ones on the left are not crossed. And this is more, of course, an extreme case of right brain stroke with associated left neglect. And in this case, if we look at the outcome, it's pretty much as clear that this person would be an unsafe driver based on the history, based on the physical, based on some special tests like the clock and the cross checking of the lines. And the deficits are physical. The deficits are cognitive, visuospatial, and may even be a visual field deficit that we didn't pick up or is obvious. And so in Canadian provinces and American states with mandatory reporting, and that's a whole other slide, but basically, for instance, in Canada, we only have 7 out of 10 provinces with mandatory reporting. And in the United States, there's only actually 7 states, 43 states out of 50 don't have mandatory reporting. But if, for instance, in Ontario, with mandatory reporting, I think we could all say that we would feel comfortable sending in this patient's name as being a potentially unsafe driver. What about this not so sure case? Someone's had a stroke, has a history of high blood pressure, was seen in the emergency room, discharged home, as we know that happens often. Sometimes I think there's a bit of a nihilistic attitude going on, like, I think in the old days we would have admitted some of these patients, but they're getting sent home and they're referred to, stroke prevention clinics like in Kingston and in Ottawa and in London and in Hamilton and in Toronto and in Pembroke, or they could come to a stroke rehabilitation outpatient clinic like we have, and you're in your office and you say, oh, there's some mild left arm weakness, there's good sensation, which is resolving. So that's that concept of sensory motor dissociation, in which one is much more prevalent than the other, and that's often associated with a subcortical stroke. You say, oh, that's a smaller stroke, maybe less impactful. And you're not so sure because the person, I said, is the, the expression walking and talking, oriented, no real visual field deficits. Patient says cognition is, well, I think it's okay, Dr. Finestone. Maybe the memory's a little bit worse, Dr. Finestone. I'm not, nothing major. And then you look in the emergency documents, and actually, what they said, the patient was a little, they used the word confused, and that seems to have really resolved. Whether that was some delirium early on, that's possible. The CT is in quotes negative, and so the message here is that, yeah, it could say negative for acute ischemia, but you're the clinician, and the radiologists are not clinicians, and so you look for other things, and you try to get your radiologist to declare and write about things like small vessel disease, also called microangiopathy, also called microvascular disease, because it's noted that there's moderate small vessel disease on the imaging report. So you're not sure in this case whether she would be safe or unsafe. And, the actual stroke-related deficit is kind of minimal. But you also know that there's small vessel disease, and it could be affecting cognition and executive function and concentration and reaction time. And maybe if we did an MRI, as you know, I said I did a CT, that maybe I'm sure it would likely show a subcortical, like internal capsule or pontine stroke. So here's the question. So do we report this to the Ministry of Transportation of the Province of Ontario? A lot of people write MOT, just for you to know, it's MTO really. Do we need more information? Can we do more in our offices, clinics to help us decide? That's why we're here today. And then case 3, you're really scratching your brain. It's a 66-year-old guy, still working. His wife tells you his wife doesn't drive. He's got all the classic vascular risk factors, hypertension. He had a cabbage, a bypass graft 3 to 5 years ago. He has a stroke. It's also kind of more subcortical, posterior limb of the internal capsule. He's got diffuse white matter changes. He doesn't know about those things. He's never heard of those things. He went to acute care. He's then went to the stroke rehab unit. He was at about 5 weeks. He has a MOCA. I purposely put it like right on the border. 25, 26 is supposed to be normal, or normal sort of, and 25, he's a little below. His trails B, he does 2 errors. He has a timing of 2 minutes of 58 seconds. We'll say what are some of the literature about timing, but it's pretty long. And he has, independent activities of daily living. He's dressing, he's washing, he's getting in and out of the shower, he's using a straight cane. And the kitchen assessment, which I like to joke, but I think I'm serious when I say that the kitchen assessment is like the best neuropsychological test in the world. Our occupational therapist said, Finestone, he's had a hard time. He had a hard time sort of organizing the grilled cheese, going into the fridge, taking out the bread and not really separating and almost getting his hand on the burner. But that's a little bit more obvious. And he's just noted to be impulsive. And then when you pin anyone down to the wall, they'll say, well, sometimes, I'm not exactly sure. And, hospitalists in acute care said, don't drive for a month. That's the CMA guidelines. That's not the law of the Ministry of Transport of the Province of Ontario. But it's a good thing. And you and I are kind of left holding the bag here. Because he's at his family doctor's office, if there's any family doctors in the office, or he comes to my office and he says, I need to drive. I can't function, Dr. Finestone. I need to pay the mortgage. I know I'm 66, but I'm still working. And it seems like he could be an unsafe driver. You're not 100% sure. I suppose the way I've written these cases, that I think in this one, maybe I'll make the next one a little less severe, but still, there's potential for him to cause an accident, was not sure, the kitchen assessment, the fact that people say he's impulsive, and reporting to the MTO seems to therefore make a lot of sense, but he was discharged before any discussion happened. And before July 2018, a letter was sent to the Ministry of Transport of the Province of Ontario called a medical condition report, generic kind of report, and there would be an optional section in the form, and I would have written, I think in this case, should have testing at a specialized driving evaluation program before getting back on the road. In the post-July 2018, go online, get the new forms. There's actually a new form that in preparing for this talk that is. just more for just to be a little more efficient with faxing. And the new MTO guidelines are moderately different, and I think going through them helps us to understand even they're good guidelines, and they help us to understand what's going on with the whole issue of reporting. So let's just go through the actual guidelines. I sort of pick them out, and we sort of retype them, and we'll go through them. This is since July 2018, long-standing negotiations with the Ontario Medical Association and the Ministry of Transport, and finally this came out. So before 2018, it just was, this was the major definition that only legally qualified medical practitioners, doctors, would be able to report to the ministry, and you put the name who is suffering from a medical condition that may make it dangerous for the person to operate a motor vehicle. And so there was the Highway Traffic Act, and as we see, the prescribed person could only be a physician, and that has changed. Now, for the purposes since 2018, just that there are other individuals who can report. An optometrist, of course, visual information, a nurse practitioner, a physician, and also the occupational therapist, who's often the driver of this process, are not obligated to report, but have discretionary reporting. So they actually define who is the person who can report, what the nurse practitioner, basically anyone is part of their own college. So what are the things on the form and how it's been subdivided? What are the medical conditions and impairments and visual stuff that you have to report, and which is now on the form, which to make it a little easier, so at least you could scan through this and see what you want to tick off. And as we'll see, it's like a spiral. It doesn't mean that one is exclusive. There's others that could be just as relevant. Don't worry about that, in my opinion. So cognitive impairment, affecting attention, sequencing, memory. Now, I guess you could read it into it a little too detailed. You could say it results in substantial limitation of the person's ability to perform activities of daily living. So medical students and people we've discussed and said, oh my God, that's a little like really activities of daily living, not instrumental activity. Yeah, again, got to use your judgment. It's what is substantial. There's not really a guideline or definition you can consult, but we have to use our judgment, and that's what we're here for. And so they actually have conditions in which cognitive impairment, as you can see, it's funny that actually stroke is not in this cognitive impairment. It's because it's later on, but often I will pick other still, because if I think there's some cognitive impairment, and write in stroke, because they do look at it. And then there's the number 2, sudden incapacitation, a disorder that has a high risk of sudden incapacitation, sudden moderate to high risk of recurrence. So then they give you specific things to tick off. So this is where seizure, fainting episodes, and then that's where the stroke section is, CVA resulting in physical impairment, cognitive impairment, visual field impairment. Again, if you want to write something in, you can write something in. And other things, narcolepsy, sleep apnea, hypoglycemia, uncontrolled diabetes, and you could write some things in. So it's pretty good. A motor or sensory impairment, separate section, a condition or disorder, writing in severe motor impairment that affects coordination, motor, doing the word severe. I suppose we could use that to help us if like you say, well, it's not that severe. Okay, at least it gives me that ability to use my judgment. Muscle strength, control, flexibility, and then neurological disease. That's where, again, you see there could be another, you could throw in stroke in here. So it doesn't mean just because you put it in 2 that you can't put it in here. And then visual impairments, more associated with the optometrist, but certainly we see patients with visual field deficits, with diplopia, with up and down diplopia, side to side diplopia, INOs, different eye syndromes, often associated with brainstem infarcts that you'd want to put in. And then just to remind us that there are other things besides stroke and other conditions, substance use disorder, uncontrolled substance use disorder, excluding caffeine and nicotine, kind of interesting, and the patient is non-compliant. Tick that off. I think it's probably less likely, but it does happen. Psychiatric illness, which involves acute psychosis. You could read that. And then this was interesting. If you go a little bit in the weeds, you see that a person is not required under section 2003 if the condition is transient or non-recurrent. And I guess this came about, for instance, with things like if someone went in for a meniscectomy of the right knee, a lot of times the orthopods will just sending out a million letters. Here we're saying if you know it's going to be going away, you can still tell a patient and it's not going to go away. My friend went for an umbilical hernia and the surgeon said, well, don't drive for 24 hours because you have pain and you're on opioids. So that was because he knows the consequences of having a hernia surgery, that it's going to go away, that there are maybe some drugs early on. So that would be a good example of that you would not necessarily be required. And before it wasn't clear, so that's a good thing, these ideas. And a person is not required. This one is a little hard to determine, this one. Not required if in the person's opinion are attributable to a process of natural aging. What the heck does that mean sometimes? But then they say unless the cumulative effect of the changes constitute a condition or impairment described in section 3. So again, we got to use our judgment. I mean, we know in stroke, vascular, cognitive impairment, it's not natural aging, but it's happening. And so that's not certainly going to be something that you're going to say, oh, because that's just being good. It's an obvious thing that it's going to continue occurring and getting worse, that I'm not going to report that. Again, got to use our judgment. And that's what the MTO says to us, use your judgment. Those are the methods. Then there's 7. They say, well, listen, if something doesn't really fit within those 6, we want you to still report. We want you to still use your judgment. So we're going to call that discretionary reporting of a medical condition. And basically, this is the old definition pre-2018. And what that is, so I had called the MTO to say, okay, what if they don't fit? So yeah, if it doesn't fit in 1 to 6, use 7. And usually, not 100%, they've said that if you put 1 to 6, it's going to lead, the patient's going to get a letter about suspension. But if you put it under 7, they may not. But I've had patients who they were. Because it depends what you write also in the space that's available to you in the section 7. All right. So, and then there's actually in the MTO thing as well that, look around, see what's available. There's a thing called the CCMTA, and then, of course, the CMA guide to driving that is a cornerstone that we all look at. And, at the bottom line is at the end of the day, if you want to summarize the CMA guideline, it's like if you think they have a condition that could affect their driving, report them. So that's kind of where it all comes about. But you'll see it's nice that there's lots of sections, section on drug abuse, section on pain, section on stroke, section on cardiovascular disease, section on syncope, etc., etc. So at least you can look up, and they're usually 1, 2, or 3 pages long. So it's kind of handy. And although it's a very empirical document, it's still used around the world. So we have to know about it. And that's where the 30 days comes out. Because in that section, that I'm one of the editors, 30 days, tell the patient 30 days. But too many people think that that's a Ministry of Transport guideline. As you see now, it isn't really, but it is also because the ministry says consult this document. What about occupational therapists? So Lynn Hunt looked through these things. We found some documents to explain that a little. And it's basically to the occupational therapist in the audience, this is what your people have written. That's not a legal requirement, but it gives you authority to report using the same definition pre-2018. And you could report concerns, and you can make a report without the client's consent. And you can make a report if you've met the client for assessment or a service delivery. Again, it's not just whether you're assessing for driving, it says here. It says that if you in the course of your work. And you can report on both prescribed conditions and any other medical condition that may make it dangerous. So they're giving you some authority. They want you to be evaluative of these issues. And you're still protected from law, from legal action, just like physicians are. And I guess your college has told you that, if you don't report, what does that mean? If you really think that this person has a condition, which could have a danger to drive, which could have an impact on their life and on the life of people in the community, this is not me writing this. This is the reporting unsafe drivers, new role of OTs, that you still think about your professional obligation to do so. And here it says, and taking action to address this concern is expected of the OT. Taking action may or may not include making a discretionary report. So I guess your college has told you that we'd like you to think seriously about this. So this is the newest form. I've given my first talk about this, a little shorter in Kingston, but so as soon as you see, you always have to keep up. So this is the newest form, just came out, because the first, it has nothing to do with any change in information, but it's just because the first, it has 2 pages now compared to 1, and that's causing a bit of havoc according into the MTO, because it has 2 pages, and the second page has to have the name as well, and the birth date, so that's a problem. So here it has that fax cover information, which you didn't have before. So this is the actual form, which anyone can get online and print in a PDF form. So we're doing well. So I was thinking of this slide. I think I may have got it from Sean Marshall. I may have got it from group. The stakeholders in driving, the driver, the family, the public. Then there's other there's the healthcare professionals, not just doctors, the ministry, the police, research. I was thinking, wow, like if we have an oncology issue, I don't think we ever consider that we have to get the police involved or that there's legal implications. So that's what makes this issue of the medical or healthcare provider evaluation of driving and the issue of safety, it's a different issue because look at all these players involved here. And again, oncology, cardiovascular disease, yes, I'd say there is something, but a lot of other traditional medical things and conditions, we don't have this sort of interplay with society and psychology and neuropsychology and all these things. So it makes it fun and interesting, but nerve-wracking. So, in the home stretch here, how do we assess patients in the office and the clinic? We've given little hints and clues. Let's try to be a little bit more focused. And even when we try to be focused, you see, oh my gosh, there's so many different things. We still have our personal beliefs, whether our mothers or fathers or grandfathers are driving around in a crazy state that we think they should be stopping driving, and we don't. We have our clinical experience. And then probably I should have blown up this sentence even more, the history, and including the family members' accounts, because let's face it, every patient thinks they're the greatest driver in the world, and family members are key. And sometimes in front of them, you say to the patient, do you mind, Mr. Smith, that I ask your wife here and family? No, I don't mind. And then you ask them what's been going on. And you're going to get amazing results. And you're going to get results when you see the person waving their hands behind the patient with a sour face or something. And the physical exam and paper and paper test, and also looking at the brain imaging, it's all relevant, like we said, with the microvascular disease. And then we said the driver's guide, and then any research, and then the law, because Alberta doesn't have malnutrition reporting. Nova Scotia doesn't have malnutrition reporting, but Ontario does. And then in the context of all this is that there's this emotional issues that the patient wants to either get their license back or they don't want to lose it in the first place. And that's tough on us, and we have to acknowledge that. And there's nothing wrong with acknowledging that. Because on the one hand, they tell us, oh, OT, speech, language, we're not supposed to be determining, just give us the information, just report if they could be a potential drive. But on the other hand, we know that what we're doing has a big impact. So gathering as much information is going to facilitate our decision making and make it easier for us. So this is one document. I threw it in for old time's sake. It was from a geriatric group. And to remember this, I don't really use this, but I thought in case I threw it in the slide in case someone wants to look at the slides later, is a safe drive, different things. You see, oh my gosh, like how many things do you have to look at, and how it's pretty intense evaluation to whether a person will be safe and competent behind the wheel. So I'm heading to the big three. So I think Jane Somer, we call it the big three. Sean Marshall, I don't know if he's used that word, but we sort of say, what are these things that are sort of fundamental, history, physical, all? The clock is the clock is the clock. It's probably the best test I could do on my regular day-to-day. Even now I'm doing virtual care and seeing patients on the inpatient ward, but seeing patients through the computer and through the monitor. you could still get people to do a clock, get the family member to put a piece of paper. Even on the phone sometimes, you could get people to do a clock when you can't see it, because you'll get patients have been reporting to me they're lousy clocks. So anyways, clocks are good, and everything from how they draw the circle to the numbers, and of course these are very extreme. This is an extreme example. And I wanted to look up, in the MOCA, there's only, let's say, 3 scores, but there's a million articles on clock scoring, an interesting thing, how they draw and inside the outside, and it's just interesting to see that how the arrows are drawn, that there's more. And even Sean, Dr. Marshall, has pointed out to us, what about even time? If someone's taking so long to do the clock, isn't that relevant? Of course it's relevant. And then there's the Trailsby. So in the third part of the Holy Grail, so Trailsby, again, nothing is absolutely predictive of safe driving, but Trailsby is a damn good test. And I just threw this out there in case people don't know. This 3 or 3 rule, 3 errors or 3 minutes. That's an extreme example. So if you have that, it's like a slam dunk, as we say, that you're not going to allow that person to get on the road without having a driving test. But a patient at 2 minutes and 58 seconds, be reasonable. Don't use this as a hard endpoint. This is many standard deviations abnormal, but it's still a good rule to have. And the Montreal Cognitive Assessment, basically in stroke, we're not using MMSE, I think, ever, maybe an occasional when the patient is really lower lying in. And why is it good? Why is it being adopted all around the world with multiple languages, with with phone versions? It's because it covers a lot of the ground in one relatively small test. But it's not so easy also. Remember that it still takes skill and it still takes time, and it can't be done in 5 minutes. And Jane, our outpatient nurse, who I'm fortunate who will be able to do it many times, you need a quiet room. You need to be able to address the patient properly. You need to be able to give them good instructions, etc. But great, great, great. So we do all this stuff and we say, okay, what's our possibilities? Are they fit to drive? Are they not fit to drive? They may be fit. And I call that the gray hair producer. That you're just not sure. And let's face it, that's rehab. These are the patients that we're getting paid the big bucks to do. So patients not fit to drive, like the one we showed in the first case, it's obvious. You try to discuss the patient and with the family. This is stuff that is out there. Be firm. This is a new line of the last year or two, and it seems to resonate not too badly. Mr. Smith, if I didn't report you, I'd lose my license. So I didn't use that until about a year or two ago, and kind of effective. I don't know if people sometimes they'll say I don't care, but I think sometimes also the next line is asking the wife or husband what they think the deficits are. You think they wouldn't say anything, but sometimes that's effective, and try it. That in front of everyone, if the family's there, or in front of the husband or wife, they'll say what the deficits are. And first of all, it gives you some information, and second of all, it brings it out into the open. And other transportation. And I like this last line. Oh yeah, do not argue. They may have limited insight. Yes, that's true. Medically fit to drive. So right away, when Lynn Hunt, our occupational therapist, saw this slide, she said, "Oh, I can't support this slide." I know what she meant. So what basically we know is in Ontario, you got to be able to drive to be able to drive to be able to drive. There's no limitations in your driving. We can't write that you could only drive short distances or you can't drive in the dark. So in other words, we don't want you to think that this slide says that we could say, oh, you can't drive in the dark, but we're going to just give you some advice. So no, these are just things really what patients self-limit themselves, driving on limited roads, driving slowly. And I suppose, like in some other provinces like Saskatchewan, where they have limited restricted driving license, this may be more relevant. And then the classic further driving assessment is required. So this is where you're just not sure. Sometimes I use the analogy, listen, we want to see you in a canoe. We could put a canoe in the room, or we could put you on a bench, and we could put a stick in your hand, and we could see how you're canoeing, and we could see your balance. But sir or ma'am, we got to see you in a car to know if you're going to be safe and not going to kill anyone. So that's where the thing called the functional driving assessment is approved by the ministry. There's centers all across the province. It's really our gold standard still, and includes a clinical aspect and a questionnaire aspect and on-road assessment. which completed by the occupational therapist. And it's the job of the driving evaluation to report to the ministry. That's what that line means. So like that's good that I used to think at one time years ago that you got the information and then you had to report to the ministry. No, they send the information direct to the ministry. So that's very good for us. So as Lynn made some of the nice pictures and these slides, what is the functional driving assessment determines the client's abilities, impairments, insight, and ability to learn. And you see, it's not just like physically driving the car, using vision, cognitive, visual spatial tests, physical tests. And we threw in this driving simulator because we want a driving simulator to use it. I think it would be a great idea. We don't have anyone out there has one. It's not acceptable for ultimately determining fitness to drive, but it could give some insight. And it's completed in a vehicle that has to have a dual brake, and it has to have an occupational therapy and a driving instructor. So explain that to your patients in case anyone out there doesn't know that that's what's going on. And it's a standard route, residential, moderate business traffic, highway. And Lynn wrote this in. She wrote that maneuvers that drivers have difficulty often are right-of-way situations, left turns, lane changes, intersections. Thank you, Lynn. And what's the outcome of this assessment? Well, this is, over the years, you see, it's not just pass-fail. Of course, that's the biggest outcome. But sometimes Lynn Hunt or any of the occupational therapists out there will say, well, you know, the person's rusty. The person's hasn't driven for maybe a year or two because they couldn't get their license and they're waiting for this driving test and they're getting better. So let's have some lessons for that person. And there may be some physical modifications, even if they're totally cognitively intact, but they may have some weakness on their right side. So things like Lynn may recommend a left foot accelerated pedal, a steering knob, modifications to turn signals, levers, and other secondary controls. So this is the, as you see, the change in pedal, and here's a steering knob. And restricted license may happen, like we said, in Saskatchewan, but we don't have restricted licenses in Ontario. So, back to the third case, 72-year-old, subcortical stroke, microvascular disease, just don't get a good feeling. The planning, the organization, we said we need to have a driving assessment, wasn't so pretty to talk about it. Money comes up a lot, and we know $1,000 is a lot of money for people, but sometimes there's nothing else you do. Unfortunately, insurance programs, I've never seen one that covers it. And this person, though, passes the cognitive, like initial test, passes the visual perceptual test, but on the road testing, doesn't stop the stop sign, doesn't yield, has some difficulty following instructions, and just was felt to be unsafe by Lynn. And then we just thought we had to throw this in. Unfortunately, you know, it was laughing a little bit, not laughing, but it's kind of humorous. But these are the types of things that I thought it was such an important report that just to see some of the things that go on. So this is a person who initially failed their evaluation, but lessons. And 7 hours of lessons were completed. And the driver instructor said, you know what, Dr. Fines, he said to Lynn, he said, you know what, not really improving. But the client disagreed. So Lynn, the attended the final lesson. And interesting, physical functions, not the neck moved. There was good operation of the accelerator. There was good operation of the pedals. There was smooth and safe steering control. Safe use of the turn signals. No evidence of fatigue. So what the heck? Here, look. This looks amazing. What do we need? Why are we doing this? Well, cognitive perceptual. Some maneuvers, some errors. Multitasking. All of a sudden, it was slowed information process. Didn't adjust the speed. When a pedestrian was going across the street, he sort of just thought was going to kill the guy. Very late braking for red lights and stop signs. Poor lane position. Travel too close to parked cars. Amazing that this was in this person that had physically pretty good. So you could see in a neurologist's office or in a physiatrist's office, yeah, you're great. Initially, there's that fatigue may be an issue with regard to stroke. Initially, he was checking the speedometer and his speed control was acceptable, but then he wasn't. And he demonstrated behavior, was pretty good, but I thought this was kind of the funny line, but demonstrated aggressive behavior when he had to be told that he wasn't acting very safe. He did have a good knowledge of the rules. He could talk. His left brain was pretty good. But that sort of right brain stuff of initiation and planning was not as good. So recommendations that were significant errors were made during the lessons, including the last lesson that observed by the therapist. It's recommended that lessons be terminated and the client's license remain suspended as the client demonstrated unsafe driving skills. And and Lynn just put in this sad face. And she actually wrote, because I guess it probably was a very, very uncomfortable assessment. The client does not agree with the observation made by this therapist and the driving instructor. And this is really tough. Like, I mean, again, if we take oncology, I was thinking, so I suppose sometimes the patient will say, you're making a wrong diagnosis. You're wrong. But I don't think that happens so much. But here, Lynn has gone through the time and the effort to go ahead and do all and really be kind and really be evaluative. And at the end, I don't agree with you. And this is part of the stroke judgment, again, all this stuff. Kind of I thought I had to put a few slides there to synopsize sort of what's going on. So, we're near the end, and we're going to have time for questions. Fantastic. Medical conditions and their effect on driving ability, and stroke with its visual, spatial, and physical and visual should be considered for all patients. A wide-ranging inquiry, and I don't want to be too hard on anyone, because when I'm writing this, I feel like, oh my gosh, it's so much stuff here. Physical, cognitive, visual, spatial, even social, brain imaging reports, psychological, can identify patients who may have an impaired ability to drive. And if in the province of Ontario, not Nova Scotia, British Columbia, or Alberta, if you have driving concerns, you need to inform. And they're really encouraging to inform and discuss it with your patient, but it is, as we discussed, not easy. And always remember that there are these formal driving evaluation centers, which are our best way to help determine fitness to drive still. And I know Dr. Marshall's working on like some of the screening that we've been working for years on screening tests, but still when we're really not sure and they say the screening has indicated that there could be some lack of safety, there's nothing like an on-the-road assessment with the other assessments that we showed were accompanying. So Lynn put in this last cartoon. I'll read it to you. It says, the guy is being stopped by the cops, and it says, what seems to be the problem, officer? Sir, you didn't signal your turn back there. And then he says, I didn't know I was going to turn. Thank you, everyone. That's it.
Thank you very much, Dr. Finestone. What a great presentation. We do have about 12 to 15 minutes to take questions at this time.
Beautiful.
For those of you who have access to the chat box, please type your questions into the chat and I will relay them to Dr. Finestone. But I would like to offer a moment for those on the phone who won't have access to the chat box. If you would like to unmute yourself and speak up before I go to the chats, go ahead, please.
We need to have some dialogue here. It would be such a waste if we didn't. So guys, women, men, let's have a little chance to have a talk, which so often I promised myself we wouldn't allow that in this talk.
Okay, we do have some questions popping into the chat, so I'll start at the top. One says, I'm a physiotherapist. As a PT, I would feel professionally obligated to let the MRP know if a patient of mine presented with a physical impairment, such as severe sensory loss in the feet, that would make them a high risk for driving. Can I do so without the patient's consent? Would I be protected against legal action as the OTs are for discretionary reporting?
You know what? I think already I see I have to change my talk because really that's such an important point. So, I mean, we are a team. We are a treatment team when we're doing stroke rehabilitation under the best of circumstances. So if you have any information, I hope you can feel that you can always speak to the most responsible physician and anyone else in the team to say your concerns. That's part of your general physiotherapy practice, in my opinion. And I suppose I cannot speak for the College of Physiotherapists, but I cannot imagine that would be an issue. You're just bringing up, just like you say how the person is going up and down the stairs, just how you look talking about mobility and the mobility in bed. You're talking as a team. And I'm telling you, I rely so heavily, and it's a shame that's not in the slides, on what the physiotherapists speak about it. So yeah, so you don't have the mandatory reporting, but of course, bring it up to your team. And of course, mention that, because we all have a responsibility. And I can't imagine that you would have any sort of, that could be liability, because I would consider it part of your practice.
That's great, thank you. Another couple of questions that are linked. Somebody is asking to clarify what happens once somebody has been reported to the MTO. Are there next steps depending on who reports? So physician reports versus an OT reports. Is there a difference in what that next step is? Do they automatically lose their license? And would getting that functional driving assessment expedite renewal of license or getting through the process of formal assessment and final decision?
So great question also. And you know, theoretically next time we should have the MTO with us. There's one particularly great person who I often contact. But the answer is, so first like you said, you have the form, there's 7 points, 1 to 6. If you write in, if it's written in one of those 1 to 6 conditions, so basically they're going to get a letter, and there's only so much you could do in this 1 hour talk. They're going to get a letter that says, you've been reported, and if it's one of those conditions that's serious, it's going to say your license is being suspended. Now, many times it will say it's suspended and you need to get further medical information. So there's a second form, which I didn't bring up in this thing. It's called cerebrovascular diseases form, which the physician would receive then, or the patient would receive, and which they have to fill out. So in that form, it says, do you think it needs a driving evaluation? So the answer is they're going to get a suspension. If you filled in the discretionary reporting and didn't say that you thought they needed to absolutely be stopping, but you're unsure, then they'll get also a letter that says, you need to have further medical evaluation. And so then you're going to need to get more information from the medical doctor. There's that second form called cerebrovascular diseases form. And then it's a slow process, there's no question. And that's the problem of doing it. But once the form is filled, if the physician feels that things have really improved, so once in a while, things have really improved from that initial reporting of acute care, or even the initial assessment symptoms that I did in rehab, and 2 months later, and I didn't mention that, like say, we have sort of a rule that if the person's doing well, and OT and PT says they're doing well, and they got a normal MOCA and a normal trails and a normal clock, then we actually say, okay, we could change our mind and fill in the form, and sometimes say, no, they don't need another driving evaluation. So there's many permutations and combinations.
Fantastic. If somebody has not been reported to the MTO, but they have been advised not to drive for the 30 days, do they need to go back to their physician before they can return to driving?
Now that is another amazing question. And the reality is there an answer to that? I don't think there is an answer. So that's the problem with the 30 days. It's not really a law. It's not sanctioned really by the MTO, except that they say that we do rely on the CMA guidelines to help us in decision making. So the question is, if someone is told by acute care to not drive for 30 days, what's the next step really? And the answer is, that's a difficult one, because a lot of times if people don't go back to their doctor, then they can start driving after that 30 days. I think that's not the case. I think that 30 days is just like a holding pattern. I think that everyone should be saying, yeah, you must go to your doctor to get reassessed and reevaluated. But I don't think it's really written anywhere that that's the case. So I would say that if anyone listening to this talk, tell the patient, yeah, you have to go to your family doctor and get checked out again about driving. But if they don't, I don't know if we have a leg to stand on. If someone else has information about that, let me know, then speak up.
Perfect. Another question we have is, now this may be regional, but are driving assessments, the functional driving assessments, being offered during COVID?
Good question. Lynn, you're out there. I know it was canceled for a while. Lynn, could y'all give some, unmute yourself?
Yes. We're hearing yes.
Yes, driving evaluations are being completed both in the hospitals and the private clinics in the community. They're taking very good precautions in how they're doing the assessments in the car, with hand washing, cleaning the equipment and the steering wheel, etc. in the car. They're being very, very careful.
Are they asking for a negative COVID test before?
No, I do not believe they are doing that. No. Definitely asking the screening, the usual screening of different symptoms, yes. And our driving instructors doing that prior to every lesson also.
Thank you, thank you.
You're welcome.
Thank you. Moving on to, we have lots of great questions here. As an acute care occupational therapist, is raising the concern about driving to the physician sufficient to meet our professional obligation?
Lynn, answer that question. I don't want to answer for an OT.
Sorry, I missed that question.
Oh, sorry. The question is, as an OT in acute care, would raising the concern about driving to the physician be sufficient to meet the professional obligations?
Oh, that's a tough one. Yes, that would be the start for sure, and to discuss it with the team, working with the client. But the OT does have the obligation to notify the ministry if there are significant concerns, and the OT knows that the physician is not going to act upon that information and is not going to notify the ministry. Then the OT in the acute care setting can notify the ministry and should notify the ministry using that form.
Obviously, that's a tough one, and Lynn's being, I guess just reading the law, because it's discretionary, I would imagine that you could say if the physician was really discussed in detail about the case, but that's good to hear that Lynn said that.
Fantastic. You did mention that the driving tests, I know they range from $600 to over $1,000. There's a question regarding how do you manage the financial barriers posed by the cost of that assessment in Ontario? This individual says, I work in Northern Ontario where not driving has a huge impact on patients, and access to these tests and cost present a huge challenge to patients and their family. Is there any programming in Ontario that assists with the cost, or where the assessment fees are discounted or waived?
So I'll answer this, and then maybe we'll have Lynn also. So, really, that is such an important question. And I think that the financial issue is really, it's like ridiculous how important it is, because that's one of the biggest responses that our patients have when they say, are you kidding me? $1,000? I can't do that. Because realistically, does it make sense? Doesn't it make sense that we have this test that assesses whether you're going to be a safe driver, and we're going to do that test, and then we'll have more information about whether you're going to kill someone or yourself. So it's kind of like a no-brainer, really, that we should have a good quality driving evaluation assessment kind of tool. And so if it didn't cost anything, I don't think it wouldn't be a big deal. But because of that cost, it's a huge deal. Now, we've tried every way to look into finding extra finances, and I haven't found anything in terms of, we've tried to see if private insurance companies, Ottawa's a big government town, there's private insurance, no, and they don't pay. So I don't have an answer to that, whether there's any secret agencies. Maybe someone should go after a benefactor, because I think that would be a nice cause for some well-to-do person to have a fund. Lynn, do you know of anyone that you've tried to get funds for people and being successful?
No, we have not. Certainly if they've been involved in a motor vehicle accident or a work-related accident,
right,
or if they're covered by DVA, they'll cover the cost of the evaluation. But for many of our clients, you are right, they do have to pay themselves, and I'm not aware of any. We've done things like gone to March of Dimes, etc. And sometimes we have been able to get some funding, or the MS Society, etc. But typically, no, the client does have to pay. And I can tell you that that's one of the things that I find the most difficult about the driving evaluations, is that the client has to pay for it. And then if if they require lessons, then they have to pay for that, and then a repeat on-road evaluation, plus the equipment. So it can get very costly, and unfortunately, there isn't a good solution to that. We have tried various things in the past, like the Insurance Board of Canada, etc., but have been unsuccessful in funding.
So if anyone has any connections or something to bring this forward, I think it's a very worthy cause to help some people.
Absolutely. We are running out of time, but I did want to point out that there was a question about whether or not there are any resources available to assist patients and their families in understanding the process. And somebody has answered that question kindly and directed the audience, to those who are on the phone and can't see it, to the website for the Southwest Ontario Stroke Network, which has posted a resource. This is a great resource for patients to help understand the process. So if it sounds like that's being publicly offered. So thank you very much, Rachel.
And remember that when the patient gets, besides getting that letter that's saying, unfortunately, your license is suspended or not, there is another sheet that's quite good from the ministry that says what's the next process, what do you have to do. So that's a Ministry of Transport. So go also on the Ministry of Transport website, and there are informations on what to do when you get the letter, and they try to help you quite a bit.
Fair enough. Thank you again, Dr. Finestone, and thank you, Lynn, for chiming in with some of your answers. This brings us to the end of Provincial Stroke Rounds for today. I will try and keep track of the additional answers or questions that we didn't get to answer today, and I may see if I can squeak those answers for you out of Dr. Finestone and post them to our website with the recording as well as the handout. Please take the time to complete the evaluation that was both sent to you in your email and appears in this slide deck. And hope that you can join us next month on December 2nd for our next Provincial Stroke Rounds, which the topic is Stroke in Young Adults, Causes, Consequences, and Long-Term Outcomes with speaker Dr. Richard Swartz. Thank you for joining us this morning, everybody, and thank you again to Dr. Finestone and Lynn.
Thanks for having us. It was fantastic.
Thank you.